Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a traumatic cataract. The patient sustained perforating corneal injury with a nail about 1 week ago. Since the lens matter is filling up the anterior chamber, I have taken up this case for surgery. Let us observe the surgical steps. You have probably noticed that I have taken a conjunctival rim for making the incision, and this is a paracentesis with the keratome itself. I didn't go into the anterior chamber, so this is half of the keratome is introduced. The idea is this will form a better wound, and the conjunctival rims will cause better sealing of the wounds. And now I want to stain the anterior capsular rim with trypan blue dye, and it was not very much successful. Only the rim on the right side has been stained a bit. And now I have used a Simcoe cannula 23 gauze for aspirating these loose cortical lens matter. The patient is 30 years old man, and there is no nucleus. The lens matter is soft and everything is coming out by aspiration with the Simcoe cannula. Now I can see some strand here which is at around 3 o'clock, and I'm not sure whether there is any PC rent there and whether it is vitreous strand or not. So what I do is I inject some viscoelastic substance, and I'm using a scissor, a vitreous scissor, to cut this strand at the iris, at the pupillary margin. And now I will pull it with Simcoe cannula and see if it comes out, and see how it came out. It came out very easily. Even at this stage, I am not sure whether there is any PC rent at 5 o'clock. But now I can see the posterior capsule, and I am lucky enough because the posterior capsule appears to be intact. And now I am going through the side port at 8 o'clock and removing the cortex from 2 o'clock, 3 o'clock, 1 o'clock to 3 o'clock. Hydration has already occurred by the aqueous, so I'm just gently pulling the lens fibers, and it is coming out very nicely. Here you can see this flap from 1 o'clock to 3 o'clock is a part of the anterior capsule. This corneal injury has been repaired by me 7 days back. In such cases, the prognosis is always guarded, and I say I'll try my best. I'll try with utmost sincerity, and whatever outcome happens, you have to accept it. And the patients usually listen to me. So cortical cleanup is going on very satisfactorily. Now I am going through the sideboard made at 2 o'clock and cleaning the cortical matter from 8 o'clock to 11 o'clock. And there is a part of anterior capsule from 12 o'clock to 8 o'clock. So now my idea is to trim these two parts of these anterior capsule. The part which we can see from 1 o'clock to 3 o'clock and the other part which is from 12 o'clock to 7 o'clock. And the capsule which is at 4-5 o'clock is probably behind the iris. So viscoelastic substance is injected, and now with the help of the vitreous scissor I'm making a nick here, and then I'm using a utrita forceps to tear off a part of this flap of the anterior capsule. Here it is. And now the part on the right side, an nick is made here, and then after 2-3 attempts I could grasp the anterior capsule, the tag, and here I am tearing off a portion of the anterior capsule. And now after injecting viscoelastic substance which has been edited out and increasing the wound a little bit, I am implanting this lens. This is sensor multipiece intraocular lens, and it is being implanted by a B cartridge from Alcon. And now I want to place the haptics behind the anterior capsular flaps. The trailing haptic is placed behind this flap at 2 o'clock, and the other haptic is depressed and then pulled, and it goes behind the flap which is at 9 o'clock. Now thorough cleaning of viscoelastic substance is done. I have used Simcoe first for cleaning the viscoelastic substance. Now I am using bimanual irrigation aspiration, and now my idea is to reduce the size of the pupil. You can see there is a sphincter tear, there is iris injury at 5 o'clock, and now I am with the bimanual aspiration handpiece of bimanual, I am pulling the iris towards the center, so that if there is any clogging of iris at the angle, that block is released. Yes, the pupil has become little smaller, and now after injecting some BSS into the corneal stroma on either side of the stab wounds, finally this is the final lavage, and then antechamber is nicely formed and the case is concluded. Thank you very much for watching. Hope this video will help you in developing your surgical skills. This is a 20 minutes long video, and it has been edited to 10 minutes. Thank you very much for your attention.